for even patients that are second-generation Asians. They come to get a rhinoplasty because there's other issues involved. For example, they may think that a larger nose is associated with good fortune, wisdom, and sign of wealth. If you don't ask, you won't know. I do ask for this if they're an Asian patient. There's an interesting thing that the large nostril, especially if they're flared upward, can cause problems with the idea that money's being flooded out, and that's an interesting thing as well. So you got to be very, very careful of tilting those nostrils up. I'm going to tell you about some things to avoid. Beyond that, I want to talk a little bit about preserving ethnicity. Dr. Harris is going to talk about that in the African American patient later on. I want to focus in on the Asian patient. There's some guidelines I want to use that are slightly different from what we usually think about. You heard from Dr. Zeff that the standard Western rhinoplasty or Occidental rhinoplasty, the supratarsal crease or superciliar crease is a good landmark. I like to be a little bit more conservative. I'm quite conservative with my Asian rhinoplasty cases, so I go about mid-pupil. The tip, I don't like to project too much. Now with Caucasians, I actually like to maintain very strong tip projection. Asians, I don't like to overdo it. I like my results much more subtle. And then there's a couple techniques that I have depending on how much definition I want to the tip that I'll talk about in a moment. So that's important. The strategies, I used to use silicone implants, which in the West I know we condemn. In the East, Far East, where I trained for about 6 months, it was very commonplace. I had a lot of problems. I do use silicone injections. I know there have been issues with ideas of granulomas. I have not seen that, and I've worked with doctors who have done it for quite some time, since the 60s. Fat injections are a bit unpredictable in the nose. I'll tell you how I do that. And radius injections I really don't use anymore, but it's a good alternative if you're not planning to have a rhinoplasty in the future, because it's otherwise quite difficult. My mainstay today is the last strategy, which is GORE-TEX to the bridge and cartilage tip grafting. The strategies. As I said, I don't use silicone implants anymore. If you're getting great success, there's no reason to stop. I just saw the major problem that I saw was distal migration and shrink wrapping. And it's just a very heavy product that tends to slide downward over time, or at least has that potential. When you see a patient with a very over-projected nose from silicone implant, my first instinct is not just to do a revision nose. It's sometimes, hey, let's just remove it. And what's really amazing is with the encapsulation that can occur in some of the scar tissue, their nose becomes just about right, in my opinion, after removal of the implant, which is a 5-minute office procedure. The only risk that you have to present to the patient is potentially there's going to be some areas where there could be pressure necrosis on the cartilage tip, depending on how significant that implant was, how hard it was, and how large it was. This was done in Vietnam, and you can see there was actually penetration through the skin and had to do a rotation flap to close, and also put GORE-TEX in a tip graft. So strategies also include fat injections. I do a lot of fat transfers for facial rejuvenation. I don't do a lot of them for the noses. In fact, I make it explicitly clear to my patients that I will not just do fat grafts to the nose. I think it's too unpredictable. I do it to cover some inverted V deformities, some shrink-wrapped appearances to the nose, and I will do it in combination with fat transfer and not charge the patient, since it literally takes about 20 seconds. So this is an example of a lady about 6 weeks post-fat, I know she's not Asian, 6 weeks post-fat transfer with an inverted V deformity preoperatively, as well as aging face. She's 51. And this is now 6 months post. Are those images clear? Yeah, okay, I'm just a little bit worried looking down there. And then this is about 14 months post. This is all just one fat transfer. And you can actually see that the result gets better over time. And little tiny photos here at 35, where I just try to match photos. Strategies, silicone injections, you heard, can be, if your opinion is not good, favorable, then don't do them. I don't really use it as a primary modality. I use it as a minor touch-up, a little bump here, a little something there, and I love it to correct contracted alar rims if you're very careful. I've had a case where I injected and it just became a little bit too thick on that area because the skin is so thin there. So you got to be very, very careful if you're going to do that. Of course, that's if there's no functional component. I don't do radius anymore. I actually did a few cases of that at the time when I wasn't using silicone. I just don't use it anymore. I think it's a good product in the nose. I just think the problem is if you're going to plan on any kind of rhinoplasty in the future, it becomes quite difficult an endeavor. Strategies, GORE-TEX and cartilage. This is really what I do today for probably 95% of my noses in the Asian population. I think GORE-TEX has a little bit more tenacity and doesn't slide down. It is actually relatively easy to remove through an intercartilaginous incision with a patient sedated. It's not that difficult. It feels more natural. It can shrink a little bit, but I like using the sheets and not over-augmenting. I think doing that, it has a much less chance of the shrink wrap appearance. By the way, you probably heard that GORE-TEX is off the market as of November, I think 06 or so, or around there. And preformed SAM is, and that's what I use. I really like the sheets over the blocks, although a lot of prominent Asian surgeons, such as Joseph Wong out of Canada, uses the blocks. There are two replacements on the market right now for those who are not familiar, and even some of the very experienced surgeons that use a lot of GORE-TEX in the past didn't know this. Both Implantec and Surgiform make preformed SAMs. I have used the Surgiform ones, and they feel just as great. Another reason I like the Surgiform in a way because I actually buy preformed 1, 2, and 3 millimeter sheets, so I don't have to actually fold them and crimp them. I put a 1 in, it doesn't look good. I put a 2 in, I put a 3 in, and I just like putting, because it's just a less chance of it crimping as you put it in. So you can just check with the vendors. I'm sure at least one of them will be here at this convention. Technique is I do everything open. I really feel much more control in that. It's just myself doing that. You got to be very careful as you put that SAM sheet in and look inside the entire pocket, make sure it doesn't crimp up in the superior aspect. In terms of some tip adjustments, there are a few techniques that I use for this. In Caucasians, I don't perform a lot of onlay grafts. I just feel there's a little bit of a risk over time for that to be shrink wrapped down. In the Asians, I feel as if you don't do that, you're not going to get good enough result, even being more conservative. There's two principal methods that I use. If I want a little bit more definition, I'm going to actually use a shield graft that extends about 1 millimeter or 2 millimeters anterior to the domes. If I want something a little softer look, I will use an onlay graft where I'm actually stacking cartilages to the tip. And sometimes I use it in combination. Actually, Dr. Wu's talk was really good because I do use those little fibrofatty pads, and what I do is I've never tried it as a flap. I actually just excise a little of the super tip fullness and then put it on top of the cartilage. But that's a really elegant technique, and I probably will be trying that. I caution about the dome binding suture. It's something that I do very frequently in the Caucasian nose, Western nose, but I almost never do in the Asian unless it's under-rotated, especially because the nostrils are a bit wide. And the fear is that if you put that dome binding suture in, if you get any degree of rotation of those nostrils show, even with an alar base reduction, you just got to be extremely careful with a resentful patient afterwards. Premaxillary grafts, what's really nice is to get that premaxilla down, the tip onlay, the shield graft adds a little bit of columellar dimension to it. It's good for both African Americans, some mestizo noses as well as Asians, to bring that columella down. And then sometimes I actually add a little bit of premaxillary graft with more sliced cartilage. In the past I used silicone wide blocks. Really don't like the results of that. I've had some problems with really difficult smiling with a patient as an animation. And then I use a separate nasal sill and SHEEN alar base reduction for the alar base. Alar base reductions, I don't do a heck of a lot of them. The thing you want to be careful with in particular is that if the central tip is very broad and you over-reduce a very thin ala, you can actually create more lobular look or blobular look to the central aspect. So be careful. I really like using the SHEEN flaps to reduce the chance of a notch, and I actually make a small separate sill reduction, and I do those either in combination or separately. And oftentimes what you don't see in a photograph, the patient is very happy, and patients have picked me because I work more subtly in the Asian nose. And this is just showing you the placement of the graft. And then this is the the shield graft, which you guys are all familiar with. And this is an onlay graft for a little bit more subtle result. This is a book that I wrote with Dr. McCurdy a few years ago that came out about, I think, 2 years ago by Tima. It was translated into Korean. And some conclusions to emphasize. I really want you to think about some of the cultural issues that may underscore patient motivation that you may not consider that could be a major factor. Especially if that's the overwhelming factor and the aesthetics is not a concern, you may not deliver what they want. So be on the same page. The other thing is that, as I said, I've really moved away from solid silicone implants, and I think that GORE-TEX and cartilage is very good, especially a lot of the academic surgeons that work with Asian rhinoplasty have moved away from the one-piece augmentation, as they call it, with silicone. And I really just beware of the dome binding sutures, especially if there's a flared ala. And I really want to really have you think about and be in tune with how the Asian patient thinks, which is be more conservative. Just because you want a very high bridge and a very well-defined projected tip, oftentimes a patient doesn't want that. I don't particularly care for that aesthetic, and it's okay because if patients come to me, they've pre-selected me based on my results, and I don't like to deliver results that I don't like aesthetically. So it's just, as you heard from Dr. Nassif, he's got a certain aesthetic style, I have mine as well.